Good morning. Good morning to the first plenary session of the 2011 Caribbean HIV Conference. First, we want to proudly announce, that Eddie Green has been appointed UN Special Envoy for HIV in the Caribbean, and we found this about this notice last night. So I am going to introduce the speakers for the session all at once so that we will have all the information right now. Before I go through each person, as I was thinking what to say about them, I decided that in addition to having a program where each talk is sequential and very much related in this plenary, these three speakers that we have here have so many things in common. They are pioneers in their field, and particularly in the field of HIV and AIDS. They have, all of them, given to the world scientific contributions that have moved the knowledge, particularly from some of them, the knowledge to be able to develop treatments and therapies and help curb the epidemic. They have kept the same goal ever since they started working in this field of HIV, which is to end the epidemic. At the same time, they have not lost their sensitivity towards the people that are affected or infected by the HIV. They have transcended the regional boundaries. And finally, I want to use a word to describe them. They are vintage. And the definition of vintage is wine, usually of high quality, a group or collection of people or things sharing certain characteristics, length of existence, age, and finally the one that I like the most, characterized by excellence, maturity, and enduring appeal, classic. So, our first speaker, Dr. Anthony Fauci, is the director of the National Institute of Allergy and Infectious Diseases, NIAID, since 1984. He oversees an extensive research portfolio of basic and applied research to prevent, diagnose, and treat infectious diseases, such as HIV/AIDS and others. He has pioneered in their work, particularly into the pathogenesis of HIV, and his work has made possible the development of therapies, treatments, and drugs to prevent and to treat, and perhaps even to cure HIV infection. We are very grateful to Dr. Fauci's efforts, and also to his being a facilitator of allowing funding for research in different areas. His talk is titled 30 Years of HIV/AIDS, A Scientific Journey and Look to the Future. Our second speaker, Dr. Peter Figueroa, he's a professor of public health epidemiology and HIV/AIDS at the University of West Indies, Kingston, Jamaica, where he has developed a doctorate program in public health. Another pioneer in the work of HIV in the Caribbean, and we're very honored to have Peter Figueroa with us. His talk is about the HIV epidemic in the Caribbean. Our third speaker, Dr. Bill Pape, has served as director of Haiti's GESCO since he founded this study group, and the GESCO group has done remarkable work in Haiti, and they have demonstrated that they can decrease the impact, and they have decreased the new infections in Haiti through their work and other people's work. We're also honored to have Dr. Pape has received many recognitions, international and national as well. His talk is titled The Caribbean Response to HIV Amidst Natural Disasters. And finally, Dr. Miriam Vega will react, and give us a piece of her mind after we hear these presentations. Dr. Vega currently serves as the Vice President and Director of Research and Evaluation at the Latino Commission on AIDS. She has created the Change Customized Holistic Analytical Network Building Grassroots and Evolutionary Model of Capacity Building. We look forward to hearing from these amazing speakers, and we declare open this session. Dr. Fauci.
Thank you very much, Carmen. It's really a great pleasure to be here with you this morning. I want to thank the organizers for giving me the opportunity to present to you on this most extraordinary and important topic. As you heard, the title of my talk is 30 Years of HIV/AIDS, A Scientific Journey and Look to the Future. And what I'd like to do in my time allotted is to essentially take that quick snapshot journey with you over the years, look at some of the landmarks of what has been accomplished, but most importantly, to reflect on how they will point to the future and how we may, for the first time since the 30 years of the recognition of this pandemic, that we can actually look towards some solutions. And as I get through the talk, you'll see what I mean. So first, we'll go to this matrix graph, which plots out the 30 extraordinary years from the very beginning of the realization of the first cases of HIV in 1981. We're all very familiar with the two now classic reports from Morbidity and Mortality Weekly Report. I can remember clear as day when I first saw those reports, the first one in June of 1981 reporting the first 5 cases of gay men in Los Angeles with a strange disease, pneumocystis carinii pneumonia, in otherwise thought to be healthy men. A great puzzle, why gay men, why otherwise healthy? And then 1 month later, it became clear that this was not just an oddity when 26 additional cases were reported from New York, Los Angeles, and San Francisco. And that began the extraordinary journey that we have had as participants in this over the last 30 years, the opportunity and the tragedy of witnessing one of the most extraordinary affronts to global health, literally, in the history of our civilization. So I'd like to very rapidly go through some of the things that occurred. I changed the direction of my career about 4 months after I saw the first and second Morbidity and Mortality Weekly Report. I was a rather successful, I would imagine, according to other people, I wasn't thinking about it at the time, infectious diseases immunology person at the National Institutes of Health. But I sensed something about what was evolving before us, so that I started to do only admitting patients with the strange disease, which we did not know was HIV at the time, and we didn't even call it AIDS at the time. Many of my friends and mentors thought that I was making a major mistake changing the direction of my career. So as a response to that, in December of 1981, I wrote a commentary in the Annals of Internal Medicine that was published in June, and you see the title here. And I often reflect on what I said back then, almost 30 years ago. Because we do not know the cause of this syndrome, any assumption that it will remain restricted to a particular segment of our society is truly an assumption without scientific basis. That was 30 years ago. And unfortunately, for me, for the rest of the world, what I said in that commentary turned out to be true. Because as the weeks and months and years went by, and these are successive MMWRs, you see that it became clear that it wasn't only gay men in the United States. They began to be noticed in Haitians, which was an extraordinary mistake on the part of how people interpreted that there was something about Haitians that made them HIV reservoirs, as it were. It wasn't. It was merely a function of the exposures that they had. Then people with hemophilia, blood transfusions, children, and the heterosexual partners of people who were felt to be infected, again, with HIV, but we didn't even know it was HIV at the time. You fast forward 30 years and you have what we're all familiar with, 65 million total infections, 30 million deaths, 34 million people living with HIV, and an extraordinary 2.6 million new infections each year with 1.8 million deaths. So let's go back and see how things evolved. The first couple of years, for me as a person who from 1981 was not only taking care of HIV-infected individuals, but was trying to do some research, they were truly confusing, frightening, and frustrating years. Until 1983-84, when HIV was identified as the cause of AIDS by two groups, one in France and one in the United States, such that by 1984, it was clear that we now had an etiological agent, so research could begin in earnest in understanding pathogenesis, in earnest in understanding how we might start developing therapy. Very soon thereafter, in 1985, the first HIV blood test was approved. This was extraordinary from two standpoints. From a positive standpoint, in that we were able to screen the blood supply and start to eliminate the issue of transfusion-related and hemophilia-related disease. However, what it also did is it allowed us to get a feel for the extraordinary depth and breadth of this pandemic, of which we were only seeing the tip of the iceberg. Because as we began to screen people, we found frighteningly that it was much more prevalent than we thought. Now, when you talk about advances in understanding natural history, virology, pathogenesis, that started right from the beginning, even before we knew it was HIV, because we were observing some interesting, unusual, and unprecedented defects in individuals with this strange disease. This is a slide in which I've cut off the beginning of the slide, and it's the typical course of HIV. I drafted and wrote the first version of this about 27, 28 years ago. And the reason I show it to you, because as you can see on the right-hand side of the slide, when I and many of our colleagues in this room were seeing patients, they had advanced disease, so we would see them with symptoms, opportunistic disease, and then death within a relatively short period of time. It was only after several years of observation that we realized that we were not dealing with an acute disease that gave you disease and death in a short period of time, because as you can see here, we now know that it's disease that is measured in years, several years, and the median time from infection to recognizable disease in the absence of therapy is about 10 years. This was a very important and rather unusual observation that was made. We then began, and I say we as a scientific community, to dissect out the intricacies of this unusual virus, not only its organizational components, but also its genetic makeup, which gave us great insights to understanding both pathogenesis and targets for therapy. Speaking of targets for therapy, it was the intensive work that was done on various aspects of the replication cycle that identified things which I'll get to in a moment, became very fertile targets for the development of therapies for HIV. Now, I go back to this slide again, and I wanted to show in that yellow bar what we back then were calling clinical latency. It was very interesting how, as the years go by, we realize, as much as we've done and as many advances as we made, how uninformed and naive that we were. Because we would see people, after we had the test, who looked relatively well. We called it the incubation period or clinical latency. In fact, in my lab and in Ashley Haas's lab, back in 1993, we began to probe that. And as you could see, two papers that came out at the same time in Nature, we made the statement that despite the fact that people were doing well, and remember, we didn't have good assays for virus then, we looked in the lymphoid tissue and noticed the words I used in the title, clinically latent stage, and Ashley used the word incubation period. Well, what we saw when we did biopsies of lymphoid tissue was that, in contrary to what we had thought, that the virus was actively replicating in the tissue. It was only until very sensitive serum assays for HIV became available the next year from Lifson's lab and others that it became clear that despite the fact that people sometimes looked well and felt well, there were high levels of HIV plasma viremia at all stages of infection, from the very beginning to the time that they became symptomatic. The immune response to HIV has been very, very problematic in our studies. This was so unusual. People would get infected. They would have an antibody response that was ineffective in the beginning. Only when CD8 cells became noticeable did you see a slight dip down in viremia, and interestingly, neutralizing antibody, the classical protective mechanism of viruses, was not seen until months, if not years later. Too little, too late, and ineffective, which did not bode well for the development of a vaccine. Now, what about treatment of HIV-infected individuals? The very beginning, as I mentioned, I refer when I speak and write about this as truly the dark ages or the dark era, both for the physicians and certainly for the patients and their caregivers. It was a time when you could only treat the opportunistic diseases. This is a picture of me, believe it or not, with no gray hairs there, in 1982, making rounds on patients at the NIH. And as many of us have experienced, at that time, when a person came into the hospital, they already had advanced disease, and the median survival of those individuals was about 6 to 8 months. That was a very, very difficult time for everyone. Then the first hope came in 1987 when AZT proved to have significant antiretroviral activity. That was the good news. The sobering news is what we should have predicted, that given this is an RNA virus, very soon that beneficial effect faded away as resistance emerged. As I said, we should have known, because viruses that are like HIV with high replicative capabilities will certainly mutate and have selective capabilities of averting the drugs that we use. So getting back to this slide, where you see the multiple targets, we began to develop drugs that were directed at averting resistance. And we now, as you know, have more than 30 drugs approved by the FDA and other regulatory agencies throughout the world that have profound effects on HIV. And this is an interesting slide that I made to show you how things have evolved. Back in 1987, and what's plotted on this is time on the x-axis and viral load on the y-axis. With AZT monotherapy, there was a slight dip that didn't last very long. When we started using 2 drugs, the dip went down and lasted a little bit more. It was only until 1996, when the triple combinations of what we used to call HART became available, did you have a profound decrease that was essentially indefinite if the drugs were used properly. So getting back to the picture I showed you of myself on rounds, knowing that my patients had about 6 to 8 months to live, now we know in that same clinic that I still work, if a 25-year-old walks in recently infected with HIV, and I start them on appropriate antiviral therapy, which will likely be something like a tripla, we can tell that patient, if they take their medications, that we can mathematically model that they will live an additional 50-plus years. This clearly goes down as one of the major advances in biomedical research that's translated to the good of a patient. Now, with that came the realization that this was not a developed world problem. In fact, it was predominantly a developing world problem, with 90% plus of the patients in the developing world, 67% in sub-Saharan Africa. So programs like PEPFAR, the Global Fund, Médecins Sans Frontières, and other philanthropic organizations began to pitch in with a major impact globally, so that now we have over 6 million people receiving antiretroviral therapy in low and middle income countries. That is an extraordinary positive advance. However, the sobering aspect is only about 30 to 40% of the individuals who need it are receiving it, and still for every person we put on therapy, about 2 people get newly infected with HIV. Which brings up the very important thing that I know all of you realize has been the focus, the intense focus of what we've been doing for the last year or so, although it's based on research and clinical trials that have been taking place over several years, and that is the area of prevention. So going back to this matrix, prevention started before we even knew there was HIV, because everyone suspected that this was a virus, though we didn't know what it was. We knew it was sexually transmitted, so we began doing behavioral modifications, use of condoms, etc. However, it was only recently with the scientifically proved, biologically based prevention modalities that things began to take off. And that's what we call now combination HIV prevention. And I'll go very briefly through some of these to bring you to where we are now and how I think this is going to significantly impact where we're going in the future. But before I do that, since I'm not going to talk about the science of vaccine development, we all know that a safe and effective vaccine will definitely be the game changer with HIV. However, we can't wait for a vaccine to do things that we know can be done right now. And I'm going to get to that in a moment and hopefully convince you of that. So let's get back to this combination toolkit of prevention modalities. One of the most dramatic advances was made several years ago with prevention of mother-to-child transmission. So if you look at that slide, the top black dots are what you would see in transmission if there was no antiretroviral prophylaxis. If you look at the constant application of PMTC in 2008, the line goes down to the red line, but it doesn't inflect down. So everything we're thinking about is how do you inflect it down? If you go to the blue dots, you see that's what would happen if 90% of women were reached with services that match WHO guidelines. And then the green line is that if you even include breastfeeding issues in that. The purpose of this slide is to tell you that it is without a doubt possible that we can essentially eliminate mother-to-child transmission if these are implemented in the way that we feel they should be. I'll get back to this in a second. What about male circumcision? There were 3 major studies a couple of years ago in Kenya, in Uganda, and in South Africa that showed clearly that adult male circumcision has a significant reduction in risk in acquisition among men. The important part about this, and the initial data said it was between 50 and 58%, but unlike some interventions, the fact is that if you go back and look at the durability of the effect, it's even better 4 years later, so that we now have in Uganda a 68% efficacy in blocking acquisition of the circumcised men. This is equivalent to a very good vaccine for HIV. So this is something that we need and will be scaling up greatly. What about microbicides? You know of the study of Caprisa that was in South Africa. The good news is that it was a proof of concept. The sobering news is the issue of adherence, because there was 39% decrease in incidence and 54% if people adhered. We saw the same thing in other studies. So the jury is still out on whether or not this is going to be effective. We hope so, because it will be an important tool. What about pre-exposure prophylaxis? Again, something that we can target to specific populations. A very important study in the New England Journal of Medicine in men who have sex with men showed a 44% reduction in incidence in people who received Truvada. Again, the issue of adherence, because it was 73% reduction in people who adhered 90% of the time. And if you actually did blood levels and showed that they really did take their medication, the efficacy was greater than 90%. So you have an intervention that works, but it tells us we have a lot to do to make sure that people adhere to these interventions. We know that it now works among heterosexuals. A few studies in Africa showed it isn't only in men who have sex with men, but also in heterosexuals. And then we get to the thing that really has now many people called the real game changer in this, and that is the issue of treatment as prevention, because there has been an unfortunate tension between resources that you put to prevention and resources that you put to treatment. There was a hint that treatment could serve as prevention before the study that I'm going to tell you about in a minute. One is that there seemed to be a correlation between the level of RNA and the ability or not to transmit HIV, so that viral load is the key driver. And then when you did observational studies, not prospective, blind, randomized studies, but just observational studies, it became clear is whether there was treatment or not, mother-to-child transmission decreased when viral load decreased. In discordant heterosexual couples, the lower the viral load, the less likelihood of transmitting. As then cohort studies, like in Vancouver, San Francisco, and in Southern Africa, there was a strong hint that if you get the viral load low, transmission will decrease. And then came the transforming study, HPTN 052, which showed very clearly in heterosexual discordant couples, if you start therapy early between 350 and 550 versus delaying until the viral load goes below 250, there was a 96% reduction in transmission. Most extraordinary, because if adherence occurs, then all of a sudden you know that treatment not only is good for the person, but it actually becomes an important road of prevention. So what is the factors now that we have this new tool involved in decreasing the incidence of HIV? Because as infectious disease people, we all know an epidemic, a pandemic, no matter what it is, disappears or becomes controlled greatly when the incidence of infection goes down. So there's two ways to approach that. You can prevent infection in uninfected people. I mentioned several of them: male circumcision, PMTCT, consistent use of condoms by the person who's uninfected as well as by a person who is infected, and the possibility of topical microbicides and PrEP. But there's also another factor, and that is if you decrease the pool of infected people who can transmit the infection, that becomes prevention. So being infected in and of itself doesn't mean you're going to transmit, because if you're infected, treated with an essentially undetectable viral load, you will not transmit infection. So all of a sudden, the boundaries between treatment and infection go away. I can give you multiple examples. I'm picking out Rwanda as one of them. So if you look at Rwanda with a 10 million population, they have about 170,000 HIV-infected individuals. So I'm asking the question, what about the pool of people who might transmit? So if you take that pool and just get rid of the children, because even though there are 22,000 HIV-infected children less than 15 years old, they're not going to be transmitting it to anyone. So this is the pool on this slide of potential transmitters. If you put people on therapy the way they're actively doing in Rwanda, namely 77,000 adults receiving ART, you have dramatically decreased the pool of people who could potentially transmit. And if you get more aggressive with that, and I'll show you what I mean in a moment, about treating people earlier in disease, mathematical models say you can tip the trajectory of the pandemic. So the overriding challenge that we have is to dramatically alter the trajectory of the pandemic. What do we mean by this? This is a UNAIDS slide which looks at the estimated global incidence from 1990 to 2009 in the red line. The blue line is deaths. As you can see, we're making some progress because actually in some countries we're starting to see a little inflection. But in order to get a pandemic to end, you have to have a sharp inflection down. And the reason is because as more people get infected, they add to the pool of transmitters, and you're essentially you're getting rid of the advantage you have of preventing infections. So how do you do that? This is what we are drawing. This is purely a schematic diagram. We've been working in Washington with PEPFAR, with the CDC, and creating mathematical models of what it will take to get the trajectory to essentially go down towards elimination. And it would take everything that I'm talking about, maximizing prevention in people who are uninfected and getting the number of people treated to a critical level that triggers that mathematical model. So there have been some recent recommendations from the PEPFAR Scientific Advisory Board. They're very important because if these are implemented, it would fit into the model. to accelerate coverage for people with CD4 counts less than 350, not less than 200, but less than 350. Treat all HIV-infected people with TB. Implement guidelines for treating infected pregnant women no matter what. Not only good for the women, but important for transmission to the child. Support the use of antiretroviral therapy in specific populations even greater than 350, if possible, such as in discordant couples, and intensify efforts to provide ART to the most at-risk population. So as I said in the meeting in Rome, for putting aside for a moment vaccine, today, in November of 2011, we already have enough scientific advances that if we implement them fully, it is clear that we can turn around the trajectory of the pandemic. And how are we going to do that? We're going to do it with greater efficiencies, health system strengthening, greater host country ownership of their problem, involvement of other additional countries, and importantly, an increase in final resources. So we have an opportune time right now, and it is important that we act. This is what I said very succinctly in a commentary that I wrote this summer in preparation for the International AIDS meeting in Rome in Science, where I say what I'm saying now, that we have an unprecedented opportunity based not on conjecture, but based on solid scientific data that we can actually control and ultimately end the pandemic. But major investments in implementation now will save even greater expenditures in the future. And in the meantime, countless lives can be saved. So we're going to pay sooner or later. We might as well pay now, because not only will we have important global health benefits, but we will actually save money. And as Jack Weiscarver mentioned last night in his introduction, we had the privilege and the opportunity of having at the NIH as our guest Secretary of State Hillary Rodham Clinton, who is entirely enthusiastic about what we were talking about. I've had the opportunity to discuss this with her in great detail, and as you know, as the Secretary of State, she is ultimately responsible for the PEPFAR program. She came to the NIH and she made a very passionate appeal that, in fact, an AIDS-free generation is possible. And it is up to us to prove that she is, in fact, correct. Thank you.
Thank you, Dr.
Good morning, ladies and gentlemen. I'd like to thank Carmen for the introduction and the organizers for inviting me to talk this morning, and to thank Bahamas for the warm welcome that we've all received. My topic is the HIV epidemic in the Caribbean, and the question is the tide turning? I'm going to look at the epidemic, its key characteristics, review the factors driving the epidemic, assess briefly our response, and note some challenges. Now, in the Caribbean, we have a lot in common, but there's also a lot of diversity. And we have roughly 35 million people, but there's significant population movement within the Caribbean and between the Caribbean and elsewhere, and as many as 20 million visitors annually. And as we know, many come for sea, sand, sun, and sex. We know the global situation. At the current pace, we're not going to be able to treat ourselves out of the epidemic unless we can identify the people who are infected and reach them with treatment. And at the same time, we need to reduce the number of new infections. In the Caribbean, we have nearly 250,000 people living with HIV, and nearly 20,000 people newly infected every year. We cannot go on like this. And when you look at our HIV prevalence, it is twice as high as North America, Central America, or South America. So we have a lot to do to slow this epidemic. Now, some of us will recall this famous slide in 1999 from CAREC, where we looked at the new annual AIDS case rates, and you could see in red the Caribbean was heading for the sky, while in North America the curve was heading down, and in Latin America it was flat. And this, of course, gave us great concern at that time. And if you even looked at the turn of the century, our annual AIDS cases were going up and up. And this was the challenge at the turn of the century. In those days, the estimates of how many people were living in the Caribbean with HIV were twice as high, 500,000 people. And in Haiti, we were hearing of adult HIV prevalence in the city of 12% and 5% in rural areas. So you could see the dramatic challenge that we faced. However, with the new estimates that UNAIDS has developed more recently, you can see that the number of persons living with HIV in the Caribbean has been estimated to be roughly the same between 2001 and 2009, this 250,000 people. So in fact, it is possible that our estimates of 10 years ago were overestimates. And these are the estimates that I have from UNAIDS showing the number of new HIV infections. I understand that by next week, UNAIDS may come out with new estimates, but you can see in 1990, it was estimated 25,000 new HIV infections, 100,000 people living with HIV. That doubled to 55,000 in 1993, and then it came back down to 25,000 in 1995. And we're now at the 250,000 people living and perhaps 18,000 new infections. But when you look at how these infections are distributed in the Caribbean, you can see that half of the people living with HIV are found in Haiti, a quarter in the Dominican Republic, and 13% in Jamaica. That is 87% of the persons living with HIV are in just 3 countries. And we need to single out Cuba, where it's remarkable with their size of population that they have so few people living with HIV. And of course, they have been extremely proactive in tackling their epidemic. Now, this is a slide from the UNAIDS Global Report on AIDS in 2010. And in it, they look at adult HIV prevalence and assess that in 4 countries, there was an increase in adult HIV prevalence, while in 3 was stable, 3 there was a decline. Now, I would caution how we interpret this slide, but certainly in Haiti, you can see at the bottom, 2.6 in 2001, and 1.9%. Certainly there was a decline. Guyana, I suspect so also. But if we look at somewhere like the Dominican Republic, then you can see, while they have it stable there, if you look at the demographic health survey reports that they have done in 2002 and 2007, you can see in the white bar that the HIV prevalence actually declined from 1% to 0.8%, and there were declines also in rural and urban areas. The only 2 countries to do the demographic health surveys which are population-based HIV testing are the Dominican Republic and Haiti. And if you look at the Dominican Republic, the darker the color here, it means the higher the adult HIV prevalence in the particular region. So at the top left-hand point of your screen, which is in the northwest, you can see that in that region, HIV prevalence is over 1%. And it's interesting that that is a section also. You can see a similar map for Haiti, where the darker it is, the higher the prevalence, and you can see the adjoining regions there both show high prevalence. Now, when we look at the male-female ratio, in the early days of the epidemic in the Caribbean, far more men were affected than women. Now it is approximately the same number or the same proportion of men and women being affected. However, this varies by country. So you will find in certain countries at the left of the screen, the Bahamas, 60% are females. Haiti, Belize, whereas at the other end, Suriname, Cuba, Trinidad, Jamaica, just over 30% are in fact females. So you can see that there are differences in how the epidemic is playing out in different countries. And this just captures in 4 countries HIV sentinel surveillance among pregnant women. And you can see in red, that is Haiti, and in green, Guyana, the prevalence in the antenatal clinic attendees has come down nicely. In the Bahamas, it has been more or less stable, just below 3%, and in Jamaica, just over 1.5%. So we need to get this down further if we're really going to control the epidemic. And what is particularly worrying is that among those most affected are the sex workers and men who have sex with men. And HIV prevalence is far too high. It has come down among sex workers somewhat, but among men who have sex with men, we have a serious problem. So if we look at other groups, prisoners, between 2 to 4% affected, but in Puerto Rico, where most of the prisoners have been tested, you can see it's as high as 7%. So there is a significant challenge there as well. And among those who use crack cocaine use, which in fact was among the first described in Bahamas, then you can see that in these studies, we have a problem in certain persons who are using crack cocaine. Now let's look at the epidemic curves that we've been able to get from the different countries. And this is a very impressive curve. In blue, the HIV cases you can see peaked early as 1987. And about 8 years later, in 1995, you can see the AIDS curve peaking. And what was driving the epidemic in Bermuda was primarily injecting drug use. In Puerto Rico, you can see that the curve peaked about 1992, and you can see deaths coming down. But you can see that that trajectory of the tail, as Dr. Fauci was talking, it's not coming down enough. And this shows you that in Puerto Rico, nearly 30% of it was male injecting drug users primarily, but you can see that among men who have sex with men in blue, that the proportion of persons affected is increasing. This shows the HIV non-AIDS infections in the Bahamas. And you can see here also that there is a peak in the early 1990s. And it appears as if the curve is now coming down, but it is not going right down to the flat. So that we will continue to see spread. I'm using the sentinel surveillance for antenatal clinic attenders to demonstrate the peaking of the curve in the Dominican Republic in 1995. And then if we go to Trinidad, you can see that their peak did not occur until 2004. And you can see that the number of annual cases reported remains high. So the epidemic is peaking later and staying higher in that country. And this is Barbados, and it's hard to really say there's a definite peak here because the curve is remaining very high, and this is a worrying sign. If you look at Jamaica, there does appear to be a peak around 2005, and it appears to be coming down, but it still remains high. What is interesting is if we look at the HIV prevalence among STD clinic attenders, there was a peak in this group in 1999, which was earlier than the 2006, which is the peak shown in the general reporting for HIV in Jamaica. Now, the incidence that we measured in this group was approximately 0.7% in the early 90s, and this is the curve that we got. And this just shows in Jamaica, again, HIV prevalence being fairly steady among the antenatal clinic attenders. In Guyana, again, it may have peaked in 2006, but it remains too high. So a big challenge remains here in terms of the prevalence. But really what we want to do is look at the incidence, and you can see a comparison between Haiti and Jamaica here. The axes are not the same, but you can see that there was a very steep rise in the early 90s with the HIV incidence in Haiti, and then it came down. Whereas in Jamaica, according to UNAIDS estimates, there's just been a very slow, it didn't peak as high, but just a very slow decline. And similarly in the Dominican Republic, a slow decline in the HIV incidence curves. So to summarize this, it seems as if the epidemics peaked early in Bermuda and Puerto Rico, where injecting drug use was very important driver. Peaked in 1992 in Haiti, 94 in the Bahamas, and then the Dominican Republic, Barbados, Trinidad and Tobago, Jamaica and Guyana, peaking much later and the curve remaining higher. So we can say that there has been a decline in reported HIV non-AIDS cases in most of the countries and a decline in HIV incidence in some, and the epidemic appears generally to have peaked. However, the number of new HIV infections continues to be high in several countries, and the prevalence remains far too high among those most at risk, especially men who have sex with men. There are many drivers. There's social vulnerability. We don't have the time to go through all of these, and the risk behavior. I mean, with all these drivers, it's a wonder that the epidemic has even peaked. Commercial sex is readily available. It's not regulated. And this is throughout the Caribbean. Transactional sex is also very common. And this is a survey in Jamaica where 20% reported giving or receiving no money, and another 20% reported giving or receiving a gift for sex. And this just reminds us that sexually transmitted infections are important. And this was a survey in Jamaica. And if you just concentrate on the blue bar or the purple bar, you can see that among street sex workers, over 65% of them had at least one sexually transmitted infection. The sex workers in bars and clubs, 40%. Female patrons at these clubs, 30%. And the male patrons, 25%. Other sexually transmitted infections remain important in the region. And this summarizes the reported risk behavior among adults with AIDS in Jamaica. And what is very important is that among 20%, there's no obvious risk factor, which shows that it is generalized in the population while concentrating among those most at risk. And what is driving it is the unprotected sex of heterosexual men, with sex workers, multiple partners, transactional sex, and in a small minority, crack cocaine use. And as well, unprotected anal intercourse, high rates of bisexuality, which act as a bridge to the general population, injecting drug use in a couple of countries, high rates of sexually transmitted infections, and then cultural things. The response. Country programs have led the response with support, and we must state appreciation to our partners. PANCAP, we're aiming for universal access to HIV prevention, treatment, and care, and we need to reduce the numbers by 25%, the mortality and the impact on households. We're doing well with the mortality, but not as well with the new infections and the social impact. And this just shows the scale-up of mother-to-child transmission. Some countries like Trinidad and Tobago are now at 85%. This is a slide which is slightly dated. And you can see that the scale-up of treatment has been in the last 6 years or so impressive, but it needs to go much higher to get universal coverage. It shows here that it is differentiated among different countries, but we still have a good way to go. And while deaths have declined, the new HIV infections in red have not declined in the same way. What is interesting is this case fatality curve from Barbados, which seems to suggest that case fatality was coming down before heart treatment, and heart treatment then pushed it down further. And the survival curve is the inverse of this, where you can see more persons are surviving longer. And in red, you can see that women are doing better than men, probably because they're diagnosed early with the screening. We still have significant challenges with policy, stigma, capacity, and meeting our goals. But in particular, I wanted to share this. In countries where sex between men is criminalized, it seems as if the HIV rates are higher, and we have to think about this and what it means. And a study in Jamaica showed among men who have sex with men, if they were ever homeless, victims of physical violence, or of lower socioeconomic status, they were twice as likely to be HIV infected. And this is an example of showing that vulnerability does make a difference, stigma does make a difference. And we just completed another study which shows we were able to measure incidence, and we found an incidence of 6% among the men who have sex with men, comparing with what I said, 0.7% in the early 90s among persons attending the STD clinic. So we still have a serious problem among those most vulnerable, men who have sex with men. And we have to find more effective ways of empowering and supporting the community to take more responsibility for promoting safe sex within the community. We have to provide a more supportive environment, and leaders have to promote policy that accepts that adult men who have sex with a man have a right to their sexuality, and repeal the Buggery Act. So in summary, it appears as if the epidemic in the Caribbean has peaked, new cases have declined, mother-to-child transmission has been reduced dramatically, and we've heard that both the Bahamas and in Trinidad, no cases in 2010 of mother-to-child transmission. We are getting persons on treatment, tremendous progress there, but still far to go. Mortality and morbidity has come down, survival and quality of life has improved, but those who are most at risk, the prevalence remains high, and we have a lot to do. I should acknowledge all the country programs, UNAIDS, and a whole host of individuals who contributed to this presentation and the data, and I thank you.
Good morning. Thank you for inviting me. I hope to share with you our experience in Haiti dealing with disasters. Ideally, Caribbean, in fact, is affected by hurricanes. We are at the end of the hurricane season that should end in November of this month. Earthquake and even volcanoes. If one look at a typical year, which is 2008, you'll see that the region has been affected by 8 hurricanes, including 4 Category 4 hurricanes. Haiti, unfortunately, was hit very hard by 4 successive hurricanes that occurred over a 1-month period. Earthquake as well, because you can see that there are 2 major faults, one that starts in the Trinidad Tobago area that goes north of Hispaniola and north of Cuba, and another one that goes south of Puerto Rico to the Dominican Republic, hits the capital of Haiti, Port-au-Prince, and the capital of Jamaica, Kingston. In fact, we know that earthquake will occur. What we don't know is when. Haiti has been the most fragile country in the region for the past 30 years. The GNP has been unchanged while the population increased by 60%. 80% of the college graduates live abroad. And migration is directly linked to political instability and natural disasters. Since 1986, we've had 22 governments, hurricanes, earthquake, and now 2 major epidemics, AIDS and recently cholera. I'm showing you, this past year, we've had first the earthquake on January 2010 that caused over 220,000 deaths, 1.5 million internally displaced people. The country lost 20% of the 2009 GDP. Most hospitals and schools were destroyed, particularly in the West Department. That created a huge stress on the healthcare workers. And then 9 months later, as the country was starting to recover, totally unexpected and unrelated, we have the cholera epidemic, which is the first occurring in a country totally naive to cholera, but in a population where 70% of people do not have potable water and sanitation. But the population is infected by a host of other diseases. Then 1 month after the cholera epidemic, we have Hurricane Thomas that caused much flooding, that's increasing the cholera cases. And one what I call the political tsunami, the November elections, that caused the same month political unrest in the second city of Haiti. The following month, major unrest. The country really stopped for about 10 days. In May of this year, we got a president, but it took him about 5 months to get a government. Now, this is our institution, GACECO, created in 1982 with a mission of research, service, training in HIV, AIDS, and associated diseases. We partner with the Ministry of Health from day one. In fact, the Minister of Health was a co-founder of GACECO. And also we partner with 116 local institutions. We are granted the status of utilité publique for institutions deemed necessary for the welfare of the Haitian people. We've had continuous support from the NIH since 1983 and the Fogarty since 1988. A very strong international collaboration. The arrow shows the downtown site of GACECO, one of our sites, which is located across 2 major slums, called ironically City of God and City of Eternity. And you also see the map of the UN forces. So you see we are right in the middle of the hurricane, the area where they say one should not travel. And we also have a second GACECO site, which was opened in 2009. This is the Warren D. Johnson Medical Center and the Laboratoire Rodolphe Mérieux with BSL-3 facilities. You see here Andrew Schaeffer, Chairman of Medicine at Cornell, Warren Johnson, Head of Global Health, and Alain Mérieux from Fondation Mérieux. Now, this is the situation, a brief summary of the epidemic. From 1982 to 1990, we've developed integrated HIV model of prevention and care, both in urban and rural areas. From 1991 to 2002, we're implementing and the scale-up of that model. And with Global Fund and PEPFAR support from 2003, we were extending the scale-up of ERT. You can see GACE-Cure has 28 centers, most of them in the West Department that has been the most affected by the earthquake, and the HIV prevalence that has been coming down from 6.2% to 2.2%. Came the earthquake, and the arrow shows the darkest areas that have been the most affected. You can see our downtown site, and you can also see the GACE-Cure neighborhood totally destroyed. So the impact on us was huge. We lost 4 staff members, including the head of our microbiology lab. 44 staff among the best left the country. 20% lost one parent. 70% had their home damaged or destroyed. We lost 75% of our workspace capacity at our downtown site and 50% at the recently built new site. So you can see here all our walls collapsed. So what happened is that the population from the slum just came on our campus. So what has been our response to, first, our normal mission of HIV care research and training, and then 3 additional tasks that we had to take. First, we had to set up an acute care hospital because people were coming with the worst wounds, and we are not equipped for that. So we are fortunate that we are able to team up with the US Human Health Services to offer this kind of facility. And then a TB field hospital, because our hospital collapsed, and we also had to provide TB diagnosis capacity. And perhaps the most challenging was the fact that we had over 7,000 people who were on our campus and needed complete support. So our response was first to stop enrollment in all research projects and to stop all training, concentrate on patient care and retention, making sure that HIV-infected and TB patients had enough meds. We have a practice of providing 2 weeks of extra critical drugs to our patients, thinking always that problems in Haiti will rarely last more than a week. We activated our contingency plan for tracking patients, 24-hour on-call phone lines, phone cards, correspondence, very important. This is a person that serves as the link between the patient, the volunteer, and our institution. Radio message and depot of drugs at some of our staff to make sure that it's widely spread so that in case there is a transportation problem, our patients could get it. The result is that 4 weeks later, 94% of our patients were accounted for in taking their medicine, and the 2% were accounted for in one of our other affiliated sites and taking their meds, and 211 were confirmed dead. So you could see here in blue is the total number of people on antiretrovirals in Haiti, and in red, this is our network in collaboration with the Ministry of Health. You can see that we represent over half of all people on ART in Haiti, and you also see the retention in care post-earthquake that has been fairly good. Now, we had to have our clinic outdoors because of the aftershocks. People were scared to stay in buildings, even though they were secured, so our pharmacy was also outdoor. This slide here depicts monthly enrollment on ERT in 2009 before the earthquake in blue, 2010 during the year of the earthquake, and 2011 in green. You can see that except for January of 2010, when we had the earthquake, we've been picking up the enrollment on ERT, and this year we should be doing much better with 271 patients on the average being placed on ERT. Our aim is 500. Now, let's focus on NIH research protocols. January 12, that's the earthquake. 1 year later, you can see that we've enrolled in HIV vaccine trials over 100 patients, and at present we have 1 trial that's completed and 3 trials ongoing. For ECTG, we've enrolled 200 more patients since the earthquake, and we have 3 trials completed. The CPRA study, I'll be telling you more about that. The reason why you see less patients being followed is because some have died of AIDS and 16 died during the quake. We are part of a new network, Impact. So all in all, we have enrolled over 300 patients since the earthquake, and we are the lead institution in 3 ongoing protocols, 2 ACTG and 1 HVTN. For this HVTN 7 study, which aims to enroll commercial sex workers, our incidence rate at present is 2%, which is quite high. Now, a little bit about the CIPRA study. This is an NIH-sponsored study aimed at determining when is the best time to start antiretroviral therapy. Should it be started at the then WHO recommendation less than 200 or at 350? And you can see that the Data Safety Monitoring Board, after we enrolled 408 volunteers were comparable in each group, stopped the study because there were 4 times more death in a group that started late and 2 times more TB. So everybody was placed on antiretroviral therapy at that time. So this slide here shows you what happened in terms of TB status of people, everybody on ART, and you can see that from 21 months to 45 months, those who started late continue to having a much higher rate of tuberculosis. So essentially, patients who delay initiation of ART have an increased incidence of TB even after ART start compared with patients who receive early therapy. Now, in terms of training, we are the largest training center. We've done pretty well also. That's what started the latest. We resumed training 4 months after the earthquake. But we also resumed 3 specialized training, the first MPH program that we've put in place. And I'd like to thank collaborators like Peter and others who have contributed to this program. We've started a nurse practitioner program and also a laboratory training program in collaboration with the Ministry of Health. Now, what about the other responsibilities that we had? Essentially, we had to put up an acute field hospital, and then 1 month later, create something totally new, which is a rehab center now that follows 3,000 patients on rehab. You can see at the bottom our MDR-TB hospital before the earthquake, after the earthquake, and what it is now. We have patients on tents. We've seen an increase in tuberculosis, and some of us will be presenting that at this meeting. I'm focusing here on the pediatrics and adolescents. You can see in blue, 2009, and that increase has continued for pediatrics and also for adolescents. What's interesting is that 2/3 of the kids are less than 2 years old, 60% are HIV negative. TB workload has been huge, as you can see, for TB screening. We went from 18,000 in 2009 to 30,000 up to this October. We'll reach 35,000 before the end of the year. Much increase in TB cultures and also in rapid testing. And we are detecting, obviously, many more cases of MDR tuberculosis. Now, the most challenging was the Global Health Program for internally displaced people. They came on our campus. We put them in another place that was well prepared in advance. And we've been able to offer water on day 1, set a committee to run the camp, daily evaluation of patients with fever, cough, diarrhea, and rash. That's how we diagnose many cases of TB. Immunization of children and pregnant women and prenatal care. We practically have no deaths. That's by doing those very simple things. Prevention of gender violence. We have no more gender violence, and some of it will be presented at this meeting. We created a vocational school with support of the Clinton Bush Haiti Fund, and there we've graduated 500 people in construction work. And we have a primary school for 300 kids, and there's a school being built right now that will be completed by March of 2012. Now came the cholera epidemic, as I said, totally unexpected. This is a slide that I borrowed from Scott Dowell at CDC, aimed at comparing the impact of recent cholera outbreaks of the countries most affected from 1991 to the present. And you can see that Peru led the way until Haiti came. And we're looking at Haiti at really 44 weeks of the outbreak, 4 times more cases than Peru. In fact, 1 year later, we have over 476,000 cases and over 6,600 deaths. The fear of cholera was huge. The medical staff was wearing a mask at all times. When patients started dying, they said they would rather have AIDS than have cholera. People stopped shaking hands even at church. Even some hospitals refused to admit patients, and funeral parlors also refused to accept people they felt could have died of cholera. So fortunately, our life goes full circle. When I came back to Haiti in 1980, My work was essentially in infantile diarrhea. And this slide shows you, by introducing oral rehydration and careful monitoring of patients, we're able to bring the mortality down from over 40% to less than 1%. And within 2 years, a national program was created. 16,000 health workers were trained, and the mortality, infantile mortality, dropped by half. What's interesting on the right also is a national survey that was done in 2005, much before cholera came in, and shows you that mothers were using oral rehydration therapy, and up to 70% of those who are well educated. So what we did essentially was to set up 4 cholera treatment centers. Those are large units with over 100 beds, 4 cholera treatment units, and 24 oral rehydration points. We had to train personnel in the 1,000, and we developed a model of prevention and care intensity, slums, and markets. So over a 1-year period, we've seen over 12,000 cases, about 1,000 per month. Here, it's a typical oral rehydration point that we put in a slum. So people get orally rehydrated, and if they do well, they go home. If not, they are referred to our cholera treatment centers that you see here. It was very, very difficult in November and December when we had the political problems, because all the streets were blocked and patients had to come on motorcycle, and even we used motorcycle to have our staff get water and food. This slide depicts at our 2 cholera treatment centers, we've seen 7,444 deaths, 44 patients, 18 deaths. And what's interesting is that 6 of those deaths were in people who were HIV infected. What's interesting also is the fact that in May, June, our peak was higher than in the early phase of November and December. And now we look like we are going to see another peak. So essentially, rehydration is key, IV or oral, antibiotics for anyone who is admitted, vitamin and zinc for kids, start or continue oral rehydration therapy. Think of other diseases. People, it's a sick population. They have TB, they have many other problems. So if they remain febrile, cholera doesn't give fever. They remain febrile after you know you got a problem. And you need to discharge them when they can drink and their stool volume is reduced. So essentially, what does not kill you, that's a peasant Haitian proverb, can make you stronger. The Caribbean is at risk for natural disasters and major epidemics. Our long journey has gone full circle from infantile diarrhea to AIDS to now global health and cholera. The tripod of research, training, and care gives a wide support base. Research provides the capacity to develop local solutions to local problems. Training makes it possible to identify, train, and retain the very best, to have a reserve pool to replace missing or lost staff during the time of crisis, and also the possibility to scale up nationwide successful research results. Strong partnership with the Ministry of Health is essential, as well as with local institutions. We need to build community trust with a very strong community advisory board and very strong work ethics. Leadership is essential. We need to plan ahead at all times. After each disaster, see how you can do things better. Haiti has the opportunity to build better and to provide potable water and sanitation. Management capacity is essential. One always need to have one backup for each key position. Contingency plan must always be in place with different codes according to level of emergency. And most importantly, as we are not eternal, we need to always create a new generation of dedicated staff to carry on the work. I'm sure you'll be seeing many of them during this meeting. I'd like to acknowledge many people and institutions, NIAID for HIV research support before and during the quake, the Fogarty International Center, the Office of AIDS Research, particularly for support to CHARI, the Clinton Bush Haiti Fund for earthquake support, National Cancer Institute for cervical cancer, no time to talk about that, PEPFAR and Global Fund for Patients' Care, CDC and UNICEF for cholera support, Fondation Miriam, and the organizers of this extremely well-put conference, our volunteers, our patients, our international national collaborators, and our very dedicated GSQ staff. Thank you very much.
Good morning, everyone. Awesome. Thank you so much to this distinguished panel. I'm very excited to be able to provide a response. They are warriors, vintage warriors indeed. I'm hearing the story. And the story that they talked about this morning, I don't have a PowerPoint, by the way, so this is going to be a little stream of consciousness, but bear with me, it's just 10 minutes or less. But the story that they talked about this morning is one that started with many unknowns. And due to those unknowns, stigma and fear came out. And from there, champions from the communities rose up. And we saw that there are many resilient communities out there as well that have persevered. And what we've seen in Haiti is remarkable, what you've done. What I'd like to talk a little bit about is how do we get these new innovations out to these marginalized, very vulnerable communities that are resilient, but oftentimes do not have access to many of the resources that are needed to keep this movement moving forward. When we talked about these new advances and keeping the incidence rate stable, I'd like to bring us back to something that I've always been trained to think about as a social psychologist, that behavior is the person by the environment. And oftentimes we have focused on one part, leaving the other part out. And by that I mean, oftentimes we've thought about, okay, if people are the vectors of disease, let's change their behaviors, let's change their attitudes, their norms, sometimes forgetting that behaviors occur within a context. And sometimes we have to address that context in order to help change behavior. We need to understand the person as a whole, and we also have to understand these social determinants of health that have been alluded to here this morning. Dr. Fauci mentioned that there are 30-plus medications out there right now, and that lifespan can be expanded for those that do get on treatment. But we know that many individuals have a hard time accessing care and staying on treatment. And something that we should keep in mind in trying to get individuals into care or get individuals to adhere or get individuals to take on certain behaviors, we need to alter the context and we need to take into account the 3 A's: availability, accessibility, and acceptability. By that I mean availability, making sure that whatever the intervention is, whether it's PrEP, microbicides, behavioral interventions, that they exist and that their quantity exists in relation to the population that's impacted. Accessibility. Can individuals access these products, these interventions? Is it affordable? Does discrimination stand in the way of them accessing it? What about information? And then in terms of acceptability, what are the social norms around these products? If we're talking about PrEP, what are the norms around that? Microbicides. If we look at the history, a decade ago, many people were excited about the female condom, right? They were saying women aren't empowered, we need to find some way that they can use condoms and handle that situation. So the female condom was developed, so there you have availability, right? But it wasn't in the quantity needed for the population. You also had, in terms of the female condom, accessibility. Wasn't very affordable for many populations. Many didn't even know about it. And then you also had acceptability. Those of you that work out in the field and work with women probably have heard this time and time again: I don't like them. I don't like using them. So going forward, what are we going to do around these 3 A's for these new advances? And how do we get individuals into accessing care? If we see treatment as prevention, then the first part has to be availability and getting them there. Excuse me. The other thing I wanted to mention is that throughout the presentations, we heard about partnerships, collaborations, and understanding the epidemic and understanding the culture. So I do want to put out there sort of the change model for sustainability in addressing this epidemic going forward. The change model standing for C, for understanding the culture and improving acceptability of certain interventions. Holistic, taking a systems-wide approach, addressing accessibility, being analytical, sharing, looking at the past, seeing what worked, and then applying those lessons learned going forward. The N in the change for networking, for leveraging resources. We're all here together. Let's make use of it and network, learn from each other, and then take it back to our communities as well. The G in change is for grassroots, always respecting the community, always respecting where they're at, always respecting this workforce here that understands and works with the community on a day-to-day basis. And the E in change is for evaluatory. Without data, we don't know what works and what doesn't, so always keeping in mind that aspect. Something that struck me about Dr. Pape's presentation was the 80% of the college graduates moving abroad and then 44% of the staff leaving. That means that our workforce in the Caribbean is often impacted by natural disasters. It's also impacted by what's called brain drain. Oftentimes, our workforce leaves the Caribbean and goes to other places, either for higher salaries or for different types of work hours, et cetera. We need to be able to address that as well. So addressing this epidemic in the Caribbean isn't just about getting the messages about prevention out there or about the new advances, but also taking care of the workforce that's there and that's going to stay there day to day with the population. And lastly, I'd like to address leadership. I'd like to refer to Dr. Fauci's last slide where he showed the baton. This epidemic, at first people thought, okay, it's going to be a sprint. We're going to figure this out. But then they realized, you know what? There's a lot of unknowns. We got to treat this as a marathon. But it's really a relay race in which each of the different toolkits and people who work in the different areas pass the baton to each other, but not only to each other, but to the next generation. Yesterday, we saw the youth choir performing, and I was struck by how vibrant and just how much fun they were having and how we have to involve youth in this movement as well. Many of us have been in the field for a while, and it's time for us to take that baton and pass it on to the next generation so that indeed we can have an AIDS-free generation and one that continues to be resilient. And that'll be my remarks. Thank you very much.
With this, we conclude this plenary. We thank you very much for your attendance, and let's keep this going. Thank you very much.